Why would the United States pick Kenya for an Ebola surveillance and quarantine facility? This very question has sparked a lot of anger, protests, court action, and quite a bit of confusion. For some, it's a smart public health partnership, but for others, it's a way for the United States to keep Ebola away from its borders while pushing the risk onto Kenya. But why Kenya and not anywhere else?
The short answer, Kenya is perfectly positioned. It's near the outbreak region, but clear of the immediate danger zone. Plus, it shares decades of deep health, military, and tech ties with the US. The long version? Well, that actually goes back to the aftermath of World War II. In 1946, the US launched a military medical lab in Cairo. The official goal? Protect American troops from tropical diseases. Unofficially, the US needed disease intelligence anywhere its soldiers, diplomats, and allies were moving. Fast forward to 1965, USAID sets up shop. It started with farming, family planning, and maternal health, but it planted the seeds for a massive US health footprint. By 1968, the US military expanded its medical research into Kenya, teaming up with local institutions like KEMRI, right as the University of Nairobi was opening its medical school. In 1979, the CDC arrives in Kenya, kicking off one of its deepest partnerships on the continent. Over the years, the CDC-KEMRI alliance has built advanced labs, trained field epidemiologists, and pioneered vaccine research. So, when Ebola finally captured global headlines, the US had already been on the ground for decades. But why Kenya? East Africa has the ingredients that matter for infectious disease research: a tropical climate, intense biodiversity, massive human and animal populations, and constant cross-border movement. So if you're serious about tracking new diseases, Kenya is the ultimate vantage point.
But Kenya's own outbreak experience matters too, because it hasn't just hosted research facilities, it has dealt with infectious diseases before.
In the late 1990s, Kenya faced a major Rift Valley fever outbreak. People were getting severe fevers and bleeding, and livestock were dying and miscarrying. That lesson helped push Kenya towards a One Health approach, where doctors, vets, environmental experts, and public health teams work together. Professor Omu Anzala, an infectious diseases expert at the University of Nairobi, says these cares shaped Kenya's response system. After the West Africa Ebola crisis, Kenya became part of a wider push to strengthen labs, surveillance, emergency operations, and field epidemiology. But COVID-19 became the ultimate stress test. As Professor Wanzala points out, it forced Kenya to master the brutal logistics of a modern pandemic in real time. Politically, it is a much complicated issue because public health is not just science. It also needs social license.
Under the Public Health Act, we don't need to do public participation. We are not going to consult citizens. Even members of parliament here, when they fall sick, they rush to their doctor to make sure they get the best treatment. So this epidemic does not require any consultation. Tomorrow, God forbid, if Ebola is found in this country, this house will call me back here to this chair to ask me why Kenyans die. So before Kenyans die, before Kenyans are infected, we as a government have a moral, constitutional responsibility to protect both Kenyans and other people who are non-Kenyans who live within our border or who transit within our country.
President William Ruto's message is simple. This is about partnership and not dumping.
What the American government is doing is to work with us in partnership to build the capacity to make sure that if ever we needed a facility, that facility will be there to serve the people of Kenya and to serve our friends, including the Americans. And let me say this, for the avoidance of any doubt, this is not the first time we are doing such a facility with partners. During COVID, we built a whole facility
Kenya's Ministry of Health says they've already dialed up border screenings, activated emergency teams, prepared isolation hubs, and supercharged their labs.
We have our laboratories that are ready for testing. We have the National Public Health Laboratory. We have the KEMRI, Nairobi, KEMRI, Kisumu. We have a mobile lab in Busia.
What we are doing right now also, we want to understand the population movements. Where are the main people going? Which areas are they passing? We have a lot of porous borders, and this need to be worked on. So the action is to strengthening data sharing and information sharing.
Over the last 2 days, we've been just doing a tabletop exercise, a simulation exercise, to see how our Kenyan brothers and sisters can be able to manage an Ebola outbreak in case there's a case. And the team from Uganda has been able to demonstrate some of the things, and we are now very sure that our Kenyan colleagues are able to manage an Ebola case, especially a case that goes through Busia, through Malaba, and even through Jomo Kenyatta International Airport.
But there's another important side to this story. Critics say the question is not whether Kenya has smart scientists or capable health workers, but whether an Ebola quarantine and treatment facility can be set up quickly, safely, transparently, and with public trust. Dr. Krutika Kupali, an infectious diseases physician who previously helped run an Ebola treatment unit in West Africa, says Rift Valley fever is not the same as Ebola. Her warning is simple. Ebola care needs specialized clinical care, trained staff, strict infection prevention, lab support, waste management, clear referral systems, and constant drills. Then there is public trust. Many Kenyans are not just asking, can the facility work? They're asking, who agreed to this? Who will be treated there? And what happens if something goes wrong? Will Kenyans benefit from the same standard of care?
So the question isn't just why Kenya, but can Kenya and partners build this in a way that leaves behind real capacity, not just for Americans, but for Kenya's health system too?